All right. Thank you everyone for joining Cancer Support Community today for our education session on advanced health directives. I am going to pass it over to our speaker today, Reverend Goheen from BB Healthcare.
Thank you, Kate. And welcome everyone. I'm glad that you are here and that you are interested in advanced healthcare directives. I'm going to say a little bit more about who I am and why I am here today as we go a little bit deeper into the program. I think at this point, Kate, if it's all right, we'll go ahead and bring up the PowerPoint. There, we should be up. I titled this Advanced Healthcare Planning, Your Choices in Your Family, Your Legacy, because the information I'm offering today, I offer realizing that this happens within the context of family and friends, as well as our own personal choices in healthcare. I know we tend to get caught up on the personal choices in all of this, but none of us, of course, make decisions in a vacuum. And so as we think about this process, we'll think about the people who are impacted by the decisions that we make, which I think is also important to consider along with the choices themselves. And that should... I am the Reverend Keith Goheen. I'm a board certified chaplain at VCC after my name stands for board certified chaplain. I have clinical credentials to be here and do what I do with BB Healthcare. I am the lead chaplain. I've been with BB 18 and a half years now. Much of that time was spent in the intensive care unit and the emergency department, working with folks in crisis. So I bring a perspective, sort of a bedside perspective to all of this that I hope is helpful, and it's part of my passion for getting this information out there. I also co-chair the bioethics committee at BB, and as part of my role there, I've been developing the expertise to talk about advanced healthcare directives and to also the enthusiasm to share it and how it can affect positively what happens from a medical standpoint and also for our patients and their families. Our program today, we have a fair amount of material to run through, and I'll try to manage our time on this as best we can. We'll start with an overview, and then we'll talk about decision makers and when they come into effect and what that may mean. And then we'll also be looking at the end-of-life instructions that are the second part of advanced healthcare directives. We'll cover some clinical terms. Depending on how many questions we have, I may sort of slide that down to the end. But time permitting, we'll get into some of that material as well. And then we'll talk a little bit about next steps. Having acquired the information you have, what do you do with all that? And how do we go forward? As background, the 1960s saw widespread public demand for individual and group rights. You may remember many things, many different kinds of protests and things coming up. And those of us who have clear memories of the 1960s. And in the medical field, there was a growing response against what had traditionally been thought of as the doctor's paternalism, where the doctor knew what was best for the patient and usually didn't include patients in a whole lot of decision making. Rather, they would look at the case and the person that they knew, and they would make choices. That began to change, and people felt like they needed to have more of a voice in making decisions about the kind of care that they received, especially at the end of life. And so in the 1970s, we began to see bioethics committees emerging. And the role of those committees initially was helping to bring patients' voices into the decision-making process, not only the patients, but their families as well. And out of that, we began to see legislative changes. Here in Delaware, the first law that set up what then was called a living will was enacted in 1991. So we can see it took 30 years to get from public interest to actually having legislation. And now 30 years later, we're still talking about this and learning, and people are figuring out how best to use this to meet their own needs. I like this quote from Kate DiBartolo. She says, "We call them healthcare decisions, but really it's about values. And the emphasis is not on what's the matter with you, but the question is what matters to you." This becomes especially true in a component where we talk about end-of-life care, but could really be at any point in the healthcare process. We who do this for a living know that it's possible to do too much in healthcare, as surely as it's possible to do too little. And we want to make sure that we're doing the right thing for our patients, that not only are we giving them the best medical care that they need, but we're doing it in a way that best supports their values and their goals of care. Increasingly in medical care, we're trying to not make a lot of assumptions about what the patient's goals may be. And that requires good communication on everybody's part. The advanced healthcare directives are one of those communications tools. Well, I'm curious if anyone would like to share about why you might be here today and any particular goals that you might have and what matters to you. Raise a hand if you like, or just unmute. We have a small enough group here today.
Hi. I think that for me, one of the things is so family does not have to wonder, or guess, or be. I mean, it's an uncomfortable enough situation when we're talking about end of life, but having had several family members, just have to work with them through those decisions, and not knowing in some cases, or knowing, it's just a lot better if you at least have communicated and not just completed whatever forms, but actually had those kind of crucial conversations with loved ones.
Yes, absolutely. Thank you, Claire. All right, I'm not seeing any other hands. We'll go along here. When we get to medical decision-making, who decides and when? As the patient, of course, you can decide to receive or not receive any treatment in a medical setting at any point. And that needs to be respected. That's your right for autonomy within the healthcare system. But if you do not have the capacity to make decisions, in a healthcare setting, by the way, that's a decision that your attending physician would make. And that could be for a variety of reasons. But if it's determined that you don't have the capacity to make a decision, then we need to find someone else who can make that decision for you. Ideally, that person is designated in an advanced healthcare directive, which is a written document that everyone can refer to. If not, then the medical team needs to fall back on sort of a hierarchy of potential decision makers based on the guidance we get from the Delaware state statute. And here is that sequence. If we don't know who you would like to have who you would like to have as a decision maker, this is the order that we would take things in. The first person would be a spouse. And unless, as you can see the qualifiers there, unless that person has filed a petition for divorce, or if there is a restraining order in place, the spouse is the first person. But I would note that Delaware does not have a common law statute. So if there is a relationship other than a legal marriage, we cannot recognize that other person as the decision maker, no matter how long the couple may have been together. And that unfortunately creates some real heartache sometimes, and some real confusion within families. If there is not a spouse available, we go to adult, I see child there or adult children. And again, in Delaware law, there's nothing that specifies if there's more than one child who goes first. So what we end up having to do is work with all children toward a consensus. So if you have 2 or 3 children and there's not a spouse available, we have to go to all the kids. Sometimes that's really easy and everybody's on board with that. Sometimes different children may have very different ideas about what they would like the kind of care that they would like to have their parent receive. And then we have to work through that process on the way. So again, the importance of, if there's a particular child that you would want to be a decision maker, to note that in your advance directive so that there's no question should the need arise. And you can see as the list goes down, there's parents, adult siblings, grandchildren, we get all the way down to nieces and aunts and uncles. And you can imagine if we get that far down, there could be a lot of people involved in the decision making. So good documentation is always a help. What happens if there are no next of kin who are either available or are willing to make decisions? A close friend could nominate themselves to be a decision maker for you. And that could be if you've been living with someone for a long time, that person, this is finally where they would get to have a voice. Or it might be a neighbor or someone you know from your religious community who knows you well. If there is no one friend who's willing to step forward, we would then need to go to court and have a guardian appointed. And that unfortunately is a rather lengthy process. So it may mean that we're doing everything for our patient until there's a guardian with whom we can talk about this process. And I'll pause right here. Who has questions? Sounds like we've got that. Good. So why now? Why do we want to do this kind of thing now? Anyone can be impacted by a severe injury or a sudden onset of a debilitating illness that could leave them unable to make medical decisions. And we're talking specifically about designating a decision maker. An automobile accident, a stroke, sometimes a severe infection can be enough to cause a patient to lose the capacity, at least for a little while, to make decisions. And we would need to look at someone else then to provide the answers about the kind of care that they may or may not want. Now, and again, Claire, I think you touched on this, understanding the issues and talking about your values in context with that is easier before it's emotionally difficult for family to make decisions. We would much rather work with you in the community about this than at the bedside in an intensive care unit when everything just feels more intense. Documenting your choices does reduce worry and conflict for families. We see this consistently. And it also provides meaningful guidance for the team. It removes some really important questions for them about how they should proceed in the decision-making process. There are 2 major components in advanced healthcare directive. One component designates your healthcare decision maker, or what's sometimes called your medical power of attorney. Sometimes they'll use the term agent as well. The second part records your instructions for any life-sustaining treatments that you would want to receive in case you can't speak for yourself and your doctors have determined that you are at the end of your life. And that last component is an important one there. It's a doctor's decision that you're not, that you are at the end of your life before that second part goes into effect. The durable power of attorney for medical decision-making. It's a legal form that names a person as your healthcare agent. We strongly recommend that you have a second person listed, an alternate agent listed, just in case that first person isn't available. If, for example, you and your spouse were involved in a severe motor vehicle accident, it may be that both of you are incapacitated for at least a little time. And having a second person available would be a real plus. Or for whatever reason, that first person may not be available. Having that backup, I think, is a comfort for everyone. Who should your agent be? Well, they need to be at least 18 years of age in Delaware. They need to be someone who is trustworthy and stable. Perhaps we say stable more from our perspective, because again, we're oftentimes having these conversations in hospitals during very intense times. So someone who is a little more level-headed can be an important resource to helping the decision-making process. Someone who knows you well, who knows your values, and who is accessible. And that may mean that they can come to the hospital, or at least they're accessible by phone or a video link, so that they can have regular conversations with their medical team. Someone who will make choices based on your values, including your end-of-life choices. So this is someone with whom you probably should have had a conversation about the kinds of care that you may or may not want. And someone who's not an advocate, not afraid to advocate for your best interests. They're there to speak for you, to be the person being your voice, not necessarily speaking what they may want for you, but what you need. And that's an important distinction. And ideally, it should be one person rather than a group. If you sort of going back, if we default back to let's say someone with 3 children, that group process can get a little complicated and really delay decision making more than you may have wanted it delayed. So if we can name, for example, one child who would then is free to consult with, work with the other children, and even the larger family. That would be a big help for the medical team to have one person that can kind of be the spokesperson for you and for the others. The end-of-life care instructions only apply when your medical team determines that you are at the end of your life. And that is a medical decision based on the clinical picture of what's happening for you. In the hospital or in another care facility, end of life means that there's little or no medical evidence that you will recover or survive a medical crisis. Primarily, the medical crisis we're talking about here would be if your heart stopped or if you stopped breathing. Some key indicators that your medical team will look at is if you have if you have a terminal condition, a very advanced end-stage chronic disease, for example, like a person who wears oxygen, 2 or 3 liters of oxygen all the time. Or if you've received a traumatic injury without hope of meaningful recovery, this could be considered under a terminal condition. It could also be that you have been found to be permanently unconscious. And someone who's permanently unconscious is not responding to their environment at all. And this condition stays in place for a minimum of 4 weeks. At that point, your medical team may find that you're in a state of permanent unconsciousness, and then we can look at what your values might be under the end-of-life care guidance. It might also happen with any advanced stage of severe, serious illness or of frailty. For example, you might think of those persons in nursing homes who've been there for years, and they're quite thin and they're doing okay getting around, but you know that, you know, it's a close balance. Anything serious for them would be a very, very serious setback, more so than those of us who are in more, perhaps more robust states of health. How do we make it all legal? Once you've filled out your form indicating who you would like to have decisions made or do your decision making, and also if you wanted to indicate any preferences about the kind of care that you would or would not want to receive at the end of your life, you need two persons to witness your signature on that document. And they cannot be relatives, people who are not going to inherit from you. They simply witness that these are your wishes. The signing can be notarized, but a notary is not required. A directory that is notarized but doesn't have the witness signatures is not technically valid in the state of Delaware. It can still be a useful guide for us, but it is not officially valid. So what do you do with it? Sharing is caring. You give copies of your advanced healthcare directive to your healthcare decision makers. Your primary can put it into your medical records. Anyone else, maybe any specialists that you're seeing and you want to make sure that they know also, provide that to them for their records as well. If you're brought to the hospital, bring a copy with you or have someone bring it in after you're admitted so that the hospital can get it into their records and have it available for all of your caregivers to see what your decisions might be and who you want us to talk to should you not be able to make decisions. And then think about other people who should have a copy of this. Your family members, not only the person who is designated as your decision maker, but also other people who may be involved in the decision-making process. So they know who you've designated, and they also know the kinds of decisions that you would like to have made so that they can support each other in helping the family move through what oftentimes is a very difficult time. You may want to leave a copy with your clergy person, especially if that clergy is someone who will be involved in decision-making and providing guidance to your family or friends, and also your attorney to be part of your overall medical record or your legal records, so that they have that on file as well. Having it in different places is nice because sometimes when something happens quickly, your decision maker may not have quick access to it, but if someone else can get it, all the better. Or if we already have it in the record, all the better. It can save a lot of time in hunting. And we'll pause here again. Any questions?
Okay, yeah, hi. It's Mike Jones here. Got a couple quick questions, I think.
Okay.
So I have not got a will presently. And you mentioned, you know, people who could make these choices for me. Is a person, if I have no will, but I do have people currently who are beneficiaries for some accounts like my 401k and IRA and that kind of stuff, are they allowed to be people who can sign for me because they're not specifically named in a will?
Mike, that's a fabulous question. Thank you very much. No, they can't. In fact, if you had a will made out, that the person who's designated to follow the instructions of the will can't make medical decisions either. Those persons are empowered to make decisions about your estate after your death. This is an advanced directive and medical decision-making where someone is substituting their judgment for yours for medical care, and that requires a specific form. something separate from what the will would indicate. And that's why advanced directives were created. So an advanced directive sort of works ahead of when the will would go into effect, if you follow me. Is that helpful?
Yeah, no, that sounds like that would be the primary document for this kind of medical decision making. So a will, somebody who is a recipient in a will cannot be used. And I think what you said is people who are beneficiaries of some investment accounts, a primary and a secondary beneficiary, they're not eligible either, I think is what you're saying.
Correct.
Okay. Thank you.
You're welcome. Other questions? Right, we will proceed. Life-sustaining treatments. Standard end-of-life care may include life-sustaining treatments like CPR, which is a shorthand for cardiopulmonary resuscitation, mechanical ventilation, a breathing machine. And we can say more about these things as we go on. Artificial nutrition, where we would provide fluids and essentially feed you through a tube. And there may be other medical inventions like dialysis or ECMO, certain kinds of surgeries that may or may not be helpful at the end of life. Because these treatments, while they prolong life, they do not offer any cure. And so the question kind of becomes, where are we going with these treatments? If they're not going to get us better, does it make sense to continue them? Your values come into play here, and certainly concerns for family come into play here as well. We'll talk here a little bit about CPR, or cardiopulmonary resuscitation. It's used to restore a heartbeat, and it's intended to minimize damage to other organs, especially to try to protect the brain. CPR may include chest compressions. This is kind of the famous one we see from television where they're pressing on the chest. The goal here is to squeeze the heart because the heart isn't working. So those compressions have to be quite hard and quite deep to do that. It may also include rescue breaths initially, and eventually a patient receiving CPR will be intubated, or we'll put a breathing tube in to support them. It could involve electric shocks depending on what's going on with the heart. And you will also receive medicines that are designed to stimulate the heart to get it beating again. Requirements, anyone who has received CPR is going to go to the intensive care unit, because that's the place where we support people who are on the breathing machine. And also because you need to be closely monitored, and you tend to be receiving a lot of medications to keep the heartbeat regular and just to keep it going. So the end-of-life risks, when you're doing CPR, it's not uncommon that ribs are fractured, and there can be damage done to lungs. The brain may not get enough oxygen, which can, of course, result in brain injury. And the same thing can happen for other organs. They can, particularly if they're weaker, they can have more damage. Which again makes it all that much more difficult to recover from a cardiac arrest. And ultimately, then that really the big risk here is that, are you going to be able to recover? And if you're not likely to recover from CPR, does it make sense to perform CPR in that setting? Regarding mechanical ventilation or intubation, there's a breathing tube that's placed by the mouth down into the breathing, almost to the lungs. that allows the machine to push air in and pull air out as necessary to take over breathing for the patient. This is oftentimes done to allow the patient to rest, or if the patient isn't able to maintain their breathing on their own. It's designed to support, ideally, until the patient can take over their breathing again. End-of-life risks, certainly weakness. Anytime that the machine is breathing for you, you're losing muscle strength, which makes recovery all that much harder. And there's a risk, particularly toward the end of life, of becoming dependent on a ventilator. We see patients who are unable to live without mechanical support, either constant or regular sort of back and forth support. The question is that the kind of care you would want to receive at the end of life? Would that be acceptable to your values? Hydration and nutrition. Here, you're receiving nutrition and fluids through a conduit or through a tube, and those tubes might be, sometimes it can be done intravenously, depending on what's going on. They may put a tube into your stomach through your mouth or through your nose. It can be put in surgically. Sometimes it's appropriate to do that right in either to the stomach or the small intestine to provide nutrition for patients who are unable to swallow. End-of-life risks, nausea and vomiting, certainly. There's risks of ulceration from the tube rubbing. Some of that fluid can come back up and end up in the lungs, which can result in infections and all the problems that go along with lung infections. But also fluid overload, and getting too much fluid into the body, which then may require dialysis or other things to help manage the fluids, so that one form of care can lead to other treatment options or necessities along the way, all within the context of what are we hoping for here? Can we make this person better in one way or another? Some other possible treatments. Patients may need blood transfusions or chemotherapies. Dialysis is oftentimes something we need to look at. Is the kidneys can start to fail here, and what do we do to get fluid out of the body? There may be invasive tests. If the heart has suffered damage, we might need to look at, does it make sense to put in a pacemaker or a defibrillator? If or not the patient's likely to recover from this event. You see some radiation therapy, sedations, oftentimes required here to help keep the patient comfortable with all these procedures. You may need surgeries, and then all kinds of advanced testing, which may or might not change the kinds of care that we're providing. And again, based on your values, some of these things may or may not be appropriate. What would be beneficial out of all these tests? They'd be beneficial if it relieves pain or suffering, certainly always a goal in the care that we try to provide. If it increases the quality of your life, or if it improves function. And if it falls in line with your values. When is it not beneficial to do these things at the end of life? When it would cause pain or decrease the quality of life. For example, requiring the patient to be confined to bed or severely limiting their ability to communicate with family because of a breathing tube in place or because of the sedation required to keep them comfortable. Is it beneficial to keep someone alive if it's not improving their life in any way, if it's not increasing their health? Is it in line with the values that you hold? Is this how you would want to spend the last days or weeks of your life? And I'll pause here again. Questions?
So I've got another one.
Okay.
So my parents are in their 80s and 90s, and I believe my brothers and I have been named as recipients of, I don't know, inheritance through what I think is a trust. Does that disqualify us from being the decision makers on this, or
Okay.
would we be allowed to do that?
Yeah, I realized when I answered your question the last time that uh,
Okay,
I wasn't
it's
clear on that. Yes, you can. Absolutely, you can be the decision maker.
if it's a trust, right? Because that's a separate entity.
Well, by virtue of being their child, you can do that.
Oh, a child can do it, even. Okay, okay.
Sorry about the confusion there. Good follow-up question. Others? So in a clinic, another question?
Hang on a second. Oh, yeah. So, how prepared are care facilities to sort of lay out all those sort of options, and discuss them with you? Are they generally pretty well prepared? They have somebody who's a specialist in that?
If I understand your question, typically, like in an ICU setting, the attending physician, the intensivist, would have those conversations with the family,
Okay.
or one of the other members of the medical team. Many facilities also now are developing palliative care teams. Palliative care prefers to be involved earlier, um, uh, particularly when the patient's able to have, a ready conversation around those things. So it could happen either with a primary or with a palliative physician or physician assistant.
Okay. Like in an ICU, Yeah, okay.
Yeah, you can actually have the conversation at any point. There's a point in the ICU where you have to have them, where clinically you're pressed to that corner, as it were.
Okay. Thank you.
You're welcome. Thank you. No other questions? Let's talk for a minute about do not attempt resuscitation, or DNAR, sometimes known as DNR, or allow natural death. Or what it means is that in a clinical setting, if you do not want to receive CPR, you can ask that you be given a code status of DNAR. It tells the healthcare team not to do CPR in case your heart stops. What they would do instead is do what's clinically appropriate to keep you comfortable. Use of medications, maybe a little extra oxygen or something, to keep the patient as comfortable as possible. The goal of care here is to avoid prolonging the dying process. If this is someone that we strongly feel would not recover, and the person agrees that they don't want this kind of treatment at the end of their life, we want to make sure then that we do what we can to make it as comfortable and meaningful as we possibly can. The DNAR is valid only in a hospital setting, or a nursing home or hospice or other clinical setting. It's not valid out in the community. So if, for example, you were at the Lowe's and you had a medical crisis, the EMTs responding would do everything that they needed to do to get you to the hospital, to restart your heart. They would intubate. they can't follow a DNAR. When does a DNAR become appropriate? Well, from a statistical standpoint, persons who are generally older, 65 and older, and of course, as the years go by, more so, are less likely to survive CPR. If they have a diagnosis of more than one serious illness or a medical issue that would make it more difficult for them to recover, DNAR becomes perhaps less valuable, less helpful. And for people who are end stage in their illness or frailty, again, too weak to recover from intensive therapy, DNAR may be an appropriate code status. Oftentimes going along with the DNAR is a DNI, or do not intubate. With a do not intubate, the healthcare team would not put in a breathing tube and use mechanical respiration to support your breathing. Should that be clinically indicated? The goal of care here, again, is to avoid getting stuck on a ventilator from being so sick, being so weak that you wouldn't be able to live without that support. Again, a DNI only applies in a clinical setting like a hospital or a nursing home or a hospice. And for the same reasons that we look at DNAR, is this likely a therapy that's going to get you through to get better? Or are we really, unfortunately, just kind of prolonging a dying process? By the way, when a DNAR goes into place, then DNI is automatically in effect, because when we do CPR, we intubate. But a DNI does not necessarily rule out, actually it would rule out doing CPR as well, because we can't put that tube in. I'll pause again for questions.
Yeah, the last thing you said, oh boy, now I forgot what I was going to say. I was thinking about it too hard. Could you go back to the previous slide? Let me see if it, okay. Yeah, okay. So I think you said a DNAR would automatically prevent intubation. Is that what you meant?
No, a DNAR intubation is a standard part of that. That would happen right away.
Right, okay.
So if you didn't want to be intubated,
okay.
Or if you did want to be intubated, we wouldn't be able to use the DNAR. Say that the right way there.
Yeah.
You could be intubated, but still have a DNAR, so that, let's say, for example, a patient who has COPD may need to go on a ventilator for a little while till their lungs recover, and they're expected to recover and get back to where they were. But if their heart stopped, they wouldn't want anything else done. So they could be intubated, but if their heart stopped, we wouldn't do CPR.
Okay.
But if you didn't want to be intubated, we can't do CPR either, because that would require intubation.
Okay, so pretty much universally, to do CPR, you've got to be intubated, and that's sort of universally understood throughout healthcare.
Right, that's standard protocol.
Okay.
Other questions?
Well, the example that you gave about, say, chronic COPD or COPD patient, and you're looking at intubation for a temporary period of time, I wouldn't equate that with an end-of-life situation or decision then. I mean, if we're looking at a temporary period of time on intubation, so that, because you mentioned the goal that the expectation is the person's lungs then will improve, It doesn't sound like an end of life discussion.
Correct. And that's part of the clinical judgment and all of that. But for some folks who have advanced CPR or advanced COPD, sorry, I get all my letters mixed up here, they may come to a place where perhaps they've, in the last 6 months, they've been in the hospital 3 times and they've been intubated multiple times. They get back, but they're just like, I'm done with this. I know I'm not going to get back to where I wanted to be. So please don't intubate me again. So rather than us coming to them and say, we don't think this is appropriate, they may well tell us that they've had enough. And we need to respect that. And that's a place where the DNI would be put into place. Does that make sense?
Yeah, I mean, that gives some clarification. Thanks.
Sure. And again, the material that's in the Advanced Healthcare Directive would only be used if you couldn't tell us what you wanted, and if the doctors decided that, yes, you were in fact in an end-of-life situation. So it's a fairly narrow set of criteria that we're working from. And as I said earlier, the patient can decline any treatment at any time.
Are these slides or any video available on the website of some sort somewhere?
I can, if you're okay, Reverend Goheen, I can certainly send out a copy of this presentation to everyone on this group. And then we are recording this presentation also, so it will be available to rewatch or to share with anyone who couldn't make it today.
Okay, great. Where would I find the link for that? At the CSC website somewhere?
It will be, yeah. Within a day or two, it should be under the recorded programs on Cancer Support Community website under the education topic.
Oh, okay, great. Thank you.
And if you were signed up for this program today, tomorrow I'll send out an email with any additional links.
Okay, super. Thanks very much.
Absolutely.
All righty. So the really big basic question, when thinking about medical care at the end of life, what values would be most important to you? I think this is sort of the core of what we're hoping to do here, is to get you thinking about that and to get you involved in conversations around that. And I don't know if there's anybody here who would want to venture a response to that question. If not, that's fine.
Well, I think that's a kind of a loaded question, but I don't know if this is related or not, but what would be the most appropriate way, whether it's a form or just a personal document that you prepare? These are talking about specifically what medical things you do or do not want as far as at the end of life. But what about things that are a little more on a personal perspective? They're not technically medical care, but for instance, if someone is concerned, as I know I had a family member who was, that say his or her skin is taken care of, that they're clean, their hair, like their physical appearance, because you can be at end of life for a bit of time, and you could have a lot of things in place. So you're not going to have CPR, you're not going to be intubated, etc. But you want to want to express that people whose job it is to take care of you are also considering personal care, which doesn't fall under medical care, whether it's personal hygiene, appearance, those types of things. What is the best way for someone to have those types of things communicated?
Excellent, interesting question. There is a place on our form, and I think most of the other forms, where you can put in other instructions. So certainly that would be one spot. One of the resources, and it's on the last slide that we have here, there is a tool available called 5 Wishes, and it's pretty expansive in helping people document the kind of care that they might want. So maybe looking at a 5 Wishes form and filling that out and including that, writing that in, the concerns that you lift up here as part of the 5 Wishes form might be a good resource for you or for whomever has this concern. Good question. Thank you. Others? Well, from a clinical perspective, the question that I hear most often asked, if not exactly in these words, then shall we say the spirit of that question, when your body or your brain can no longer recover, should medical care prioritize the quality of your living or the length of your life? And that can be a very weighty question, especially if we're trying to make that decision at the bedside at a time that the patient is critically ill. So having that conversation, especially the part around what would you mean when you talk about quality of life? What quality is acceptable to you? What quality of life is not acceptable to you? And to make sure that the people around you understand that and support that, and help the medical team figure out how to design their care to best support your desire. A little quote here from Hank Dunn, who wrote a book called Hard Choices for Loving People. What really makes these decisions hard choices has little to do with the medical, legal, ethical, or moral aspects of the decision process. The real struggles are emotional and spiritual. These are decisions of the heart, not of the head. Ultimately, we are hoping that the decisions that get made at these critical times are loving decisions, decisions that respect the patient, that respect the relationship that the patient has with their family and friends, decisions that are about the life that they want to lead the way that they want to lead it. And Claire, I think it was you who had mentioned earlier that sharing your values and goals at the end of life care can bring you closer to the people you love. That knowledge reduces fear. If others know what you want, they can face the necessity of making decisions more readily with some confidence that, yeah, this is really what they wanted and I want to take care of them. It means that your decision makers are prepared and that they don't have to think through this for the first time. They're already in a place that they can essentially get it. They know what it's all about. And this is a place where your instructions also demonstrate your values. In all of our relationships, the way we conduct ourselves says a lot about who we are and how we relate to the people around us. And this, in some ways, becomes a teaching for us through our instructions about what we're thinking about in life and what we value and how we want to be supported. And yeah, you can do this. You can actually have these conversations with family. And one conversation can really make a big difference. A little quote from the Conversation Project. It's always too soon to have that conversation until it's too late. We strongly recommend that you not postpone the conversation any longer than you need to. Even though it might seem terribly early right now, you never know. Here's my contact information. Going forward, if you have questions, you're certainly welcome to reach out to me, either by email or call me. Send me a text, whatever you need. We'll be happy to work further with you. And here are some of those resources that I was talking about earlier. For end-of-life preparations, the Conversation Project, we just had a quote from there. How do you go about having that conversation? Family, how do you go about having that conversation with your medical providers? Because it would be good to have these kinds of conversations with your primary care physician, for example, or any specialist who's taking care of you, to make sure that they understand your values and also you understand the risks involved with your particular medical conditions. A useful book that we recommend, Atul Gawande's Being Mortal. There are different advanced healthcare directives out there. Maybe has one on its website. There's also a link to that on the email that went out to everyone this morning that Kate was kind enough to share. Prepare Your Care Delaware has one. You're welcome to look at that. There's also more information about advanced directives there. I mentioned 5 wishes earlier. There's a link here. Possibly you could get that through when all of this is shared. For our Catholic patients, the Catholic Diocese of Wilmington has its own advanced healthcare directive, and that could be found on their website under the Respect Life section of the diocesan website. Last questions.
Can you scroll back to the second to last slide that shows your contact info? I didn't. Okay, there it is right there. I'm just going to take a quick screenshot of that. And here we go. Okay, got it. Thank you.
Fabulous. You're welcome.
And I'm going to end our streaming to Facebook, but everyone on Zoom can stay on. So if you have any questions you want to ask, this next part of questions won't be recorded or on Facebook. So if you had anything additional you wanted to ask.